Gianluigi Savarese from Stockholm in Sweden, who will be talking on renal kidney disease in heart failure. Please, Gianluigi.
Sorry, it was a mistake in the title, actually. So the relationship between heart failure and chronic kidney disease is a bidirectional relationship. So this means that actually heart failure and chronic kidney disease have shared risk factors, which are age, hypertension, dyslipidemia, diabetes, smoking, obesity, and actually chronic kidney disease might lead to heart failure by increasing volume overload, by fostering inflammation, and by leading to RAS activation, and at the same time, heart failure can lead to chronic kidney disease by reducing kidney perfusion and by the activation of the RAS system and by many other mechanisms. And at the same time, both diseases affects many and worsen many comorbidities. For example, anemia, we have been talking about iron deficiency, but also increase the risk of ischemia and affect the bone mineral metabolism and many other important comorbidities. So this is a study from the Swedish Heart Failure Registry where we try to understand the relationship between chronic kidney disease and heart failure. In this cohort of patients with heart failure across the ejection fraction spectrum, we observed that the prevalence of chronic kidney disease was higher in patients with heart failure with preserved ejection fraction, where actually the prevalence was 56% and was slightly lower in patients with FREF, where it was 46%, and patients with mildly reduced ejection fraction had a prevalence for CKD, which was more similar to FREF. So although we say that a prevalence of CKD was higher in PEF versus REF, we are talking about 56% and 46%, so overall prevalence of CKD in heart failure is extremely high, and CKD interacts also with other comorbidities as shown on the left in the case of type 2 diabetes and atrial fibrillation. And on the right, you can see the association between CKD and several outcomes. And you can see that the risk of all these outcomes, mortality, cardiovascular events, non-cardiovascular events, and hospitalization is increased when there is CKD, and the risk of events is slightly higher with CKD in patients with FREF compared with PEF. This is a very important, interesting position paper from the HFA, the Heart Failure Association, where the relationship between CKD and heart failure is explored. Actually, in patients with when there is onset of heart failure, as you can see in the graph on the right, there is a decrease in renal function, as you can see here, and the slope in decrease of renal function becomes deeper and deeper. And when we start in these patients renin-angiotensin-aldosterone system inhibitors and also ARNI, there is a slightly further decrease in eGFR, but then the slope is parallel to those without, in those who do not take this treatment. As you can see on the right, the use of CRT leads to an increase in eGFR, but then the slope in the decrease in eGFR remains parallel. And it is possible, but it is not completely known whether the start of treatments at this stage might lead to an improvement in eGFR over the time. So although RASI and ARNI may decrease, and also SGLT2 inhibitors, as we will see later, could decrease eGFR at the beginning of the treatment, it is observed here how patients who receive versus those who do not receive RASI and ARNI, who do have the same eGFR you can see here, the risk of outcome is much worse in those not receiving these heart failure treatments versus those who do receive heart failure treatments. And here we can see some important studies. These are like landmark trials for heart failure treatment. I don't know why this happens. In the SOLVE trial, the effect of enalapril on the primary outcome of the trial was the same in patients with and without CKD. Actually, the hazard ratio was very similar, 0.88 in patients with CKD and 0.82 in those without CKD. In the Swedish Heart Failure Registry, the association between the use of RASI and outcome was basically the same in those with normal creatinine clearance and in those with very reduced creatinine clearance. In the emphasis trials, in patients with CKD, eplerenone was shown efficacy in improving the primary outcome of the trial. And in paradigm trial, the hazard ratio for the primary outcome of the trial with sacubitril/valsartan was basically the same in patients with CKD and no CKD. So the landmark, the key treatments for FREF works in patients with versus without CKD, although we must consider that in these studies, patients with very severe CKD were not included. CKD, as shown in this study, is very often a reason which explains undertreatment in patients with FREF. In this study from the Swedish Heart Failure Registry, we observed that only 40% of patients with FREF with an indication for mineralocorticoid receptor antagonists received the treatment. You might think, well, this is in Sweden, so maybe somewhere else the use of the drug is much higher. This is not true. Actually, in Sweden, the use of mineralocorticoid receptor antagonists is higher compared with the majority of the rest of the world. And in the United States, for example, the use is much lower. In the graph on the right, you can see that as soon as here, you can, if I can show, yeah. Here you can see that as soon as the creatine clearance was slightly reduced, but still in the range where mineralocorticoid receptors are indicated, as soon as this creatine clearance was a little bit lower, the magnitude of use of spironolactone in this case was very, very, very much lower. So although there was still indication, and although the renal function was still in the range where the drugs are indicated, physicians stopped to use the drug. So CKD is very often intended as a absolute contraindication for the use of this drug, although it is not. And in this study, for example, risk of hyperkalemia did not predict non-use of spironolactone, but probably this is due to the fact that the effect of CKD on non-use of MRA was even more relevant than the hyperkalemia per se. So let's come to SGLT2 inhibitors, this treatment that in these 2 days we have been seen doing a lot of very important things in our patients. Here in this review that we have recently published on cardiovascular research, you can see a summary of the trials. Here you see the trials in heart failure on SGLT2 inhibitors. You can see that in DAPA-HF, PERO-REDUCE, and SOLOIST, the treatment was associated with benefit in terms of the primary outcome of the trial, and in the PERO-REDUCE, it was even associated with improved renal outcome. So these were patients with FREF. In patients with FREF, the use of empagliflozin was led to reduced risk of renal events. And here we see trials in renal disease. 2 of them enrolled only patients with type 2 diabetes beyond CKD. These are the Credence and the SCORE trials. In these 2 trials, actually the use of the SGLT2 inhibitor, canagliflozin and sotagliflozin, led to an improvement of a reduction of renal events. And finally, in the DAPA-CKD trial, which we will see more in detail later, which enrolled patients with and without diabetes and with CKD. Again, the use of the SGLT2 inhibitor, dapagliflozin, improved the renal outcome. So SGLT2 inhibitors as treatment for diabetes, as treatment for heart failure, and here we start to have also evidence in kidney disease. In the DAPA-CKD, we have benefit in patients with CKD regardless of type 2 diabetes or heart failure. So these are the many mechanisms which might explain the benefit of SGLT2 inhibitors in patients with heart failure, and beyond the effects on the heart, like in terms of hypertrophy, body weight, inotropism, chronotropism, metabolic effect on the heart and endothelial function and so on, we see also important effects on the kidney, like a reduction of albumin excretion, a reduction of intragranular pressure, an increase in osmotic diuresis, natriuresis, and a reduction in interstitial edema. So here, once again, we see that the importance of the relationship between kidney and heart failure and how SGLT2 can act on both. And this is the DAPA-CKD more in detail. You can see that in this trial, as I say, in patients with and without type 2 diabetes and with CKD, dapagliflozin reduced all the key outcomes of the trial, so the renal outcome, which included a more than 50% reduction in eGFR, end-stage renal disease, and renal and cardiovascular mortality, and also a renal-specific outcome where cardiovascular mortality was not included, and also the composite of death, of cardiovascular death and heart failure hospitalization, which was the same outcome as, for example, in the DAPA-HF, and that for any cause. So a great success for dapagliflozin in this trial, and we will soon see also what happens with empagliflozin in the same setting in the EMPA-CKD. And let's see a little bit more in detail. In the DAPA-HF, you can see that the initiation of SGLT2 inhibitors led to a reduction in the eGFR in the first 14 days, and then the curve for the eGFR in patients receiving dapagliflozin versus those receiving placebo overlapped once again later. And here you can see how dapagliflozin was effective regardless of eGFR in these lines. And on the right, you can see similar analysis for the EMPEROR-reduced trial. So a decline in eGFR at the beginning of the treatment, and then the curves tended to overlap. And the treatment effective in patients with FREF regardless of CKD at the baseline. So in conclusion, CKD is not an enemy of RASI and ARNI use in absolute, but it's a major driver of non-use of heart failure medication in clinical practice. Use of RASI-ARNI is beneficial in patients with and without CKD. SGLT2 treat both heart failure and CKD, might prevent CKD in heart failure and heart failure in CKD, but we will need more trials to be sure about these effects, and these trials are actually ongoing. The ESCHF Guidelines 2021 specify that with respect to the initiation of RAS inhibitors, HARNI, or SGLT2 inhibitors, a transient decrease in renal function should not prompt their interruption. An increase in serum creatinine of less than 50% above baseline, as long as it is less than 266 micromole on liter, or a decrease in eGFR of less than 10% from baseline, as long the eGFR is more than 25, can be considered as acceptable. So this is all from my side. Thank you very much for your attention.
Thank you, Gianluigi. Great talk.
Thank you.
One question. Now, we've seen that there's anyway a decline in renal function over time, and with the SGLT2 inhibitors, we see that there is this decline, but yet there is a benefit in mortality. So should we care about the decrease in eGFR? I mean, it's apart from the end stage renal disease leading to replacement therapy, or we just have to monitor for an acute kidney injury?
Yeah, this is a very good question. I agree. I mean, I think at least in my clinical practice, it's kind of difficult to see patients with a completely preserved renal function. I will say that the median eGFR in my patients is around 50 probably. I will say that till eGFR doesn't become something like 35, I will not care so much. I think monitoring is the most important thing, not only for the renal function, also for potassium. Usually these two things go in the same direction. So if we can ensure the right monitoring of renal function, I think we should not focus so much on the specific number for the eGFR.
Can I ask a question? It seems that we don't understand exactly the SGLT2, how it's benefit. I mean, now we have every now and then we have findings, because it's not, of course, just simple diuresis and diabetes. So it seems. So do you think that the added of SGLT on the usual treatment for heart failure, is this acting as a protective mechanism, and it's helping us to keep the other medication, for example, sacubitril, valsartan, all of these things? Now when add this, it gives some form of security regarding we are looking to this complication?
I think this is another advantage of using SGLT2 inhibitors. First of all, they slightly decrease potassium. This should help the use of other medication. They help to keep the eGFR a little bit higher. These might also have helped the use of of the other heart failure treatment. So definitely, yes, these are very good treatment per se in terms of impact of outcomes, but also like supporting the use of other treatments.
Thank you.
Maybe just finish this talk with just remind us, we have 4 medication as a pillar. ARNI, and we have MRA, and we have SGLT2. Just give us how to use these and what eGFR and what creatinine. I mean, we are practical physicians here, just to.
Yes. So according to the guidelines, but also according to some study also performed by our side, it seems like it's very important to introduce as many treatment in a very short time. The suggestion of introducing all of them in 1 month is very ambitious, but still possible. CKD might be a problem in that case, but as we say, if we monitor constantly both eGFR and potassium, we might be successful in doing this, and then later think about up-titration of treatments. I think, as we were saying, SGLT2 inhibitors and an early introduction of SGLT2 inhibitors might support the introduction of the other treatments as well, also for the very low risk of hypotensive effects. So I will say when we try to put everything in the first 4 weeks, we should give some priority to the use of SGLT2 inhibitors.
Can I ask you a question, both of you? I mean, it seems now that the titration for the anti-failure treatment in the beginning, if you go 1 year back or 2 years, we said 2 weeks to 4 weeks, and then to see the patient and to start to titrate. It seems now I want to reach to the target treatment within 1 month. So, I mean, as fast as we can. So this means that I don't expect that the renal function to deteriorate or this within this short period. So should I ignore this, or how I can continue on going faster in the way of titrating the medication?
I think CKD, the renal function might be more a problem when starting a treatment rather than when up titrating. And I think in the first 4 weeks, we might think about starting treatments rather than up titrating. This should come later. I don't think it's possible in 1 month to start and up titrate. I think from my experience in Sweden, and I think in UK as well, it's the same. It's very key, the follow-up of these patients. If it's the physician in the hospital to have the entire up titration phase, this is just not feasible because it's not possible to see a patient 4 times in 1 month. In Sweden, we have heart failure nurse-led clinic. It's basically the nurse to see the patients, check the heart rate, check the renal function, check potassium and blood pressure, and then they can up titrate the treatment without the need of the patient seeing the doctor. Then, of course, if there is the problem, the nurse will come to us. So I think in this, the guidelines really highlight how it's important to give to the patients the right follow-up, which is as important as giving the right treatments.
Yeah, and the other thing is that with the HFA, we clearly said that the way of implementing the guidelines is to use inpatient profiling. So if you use the patient profiling, then you look at the combination of blood pressure, heart rate, and renal function, then you can select which of the treatments you can start up titrating more. Also because, I mean, we have to be realistic. I mean, it's, we don't have just to look at the data that will tell us that we need to get to the more than 50% of the dose or say 100% of the dose. I mean, we see patients every day that they don't tolerate more than 5 milligrams of bisoprolol. They don't tolerate more than 5 milligrams BD of enalapril. So it's, that is the reality. So we need to phenotype patients and up titrate according to phenotypes. And we also do use the nurse in order to, but also the GPs in order to bring the up titration forward. So, thank you, Gianluigi.